officially. Dear colleagues, welcome to our dialogue in September. You probably remember that we had the last dialogue in July, then the editorial board meeting at the end of August, and now we are back with our Socratic conversation. I remind you that this dialogue will be posted in YouTube, so you can watch the dialogue also in the future if you want, or you can suggest the dialogue to your friends and colleagues. Please ask questions. You can ask questions via chat, and we will be happy to address, in particular, our host will be happy to address your questions. And here we come to our host. As usual, we have today an important cardiologist, well-known. I'm very grateful to Professor Greg Lip of accepting our invitation to our Socratic dialogue. And I also welcome Felicita Andreotti, who is Deputy Editor of the European Heart Journal for Thrombosis. So we will host Greg Lip to this dialogue. And the title is, well, you can imagine, is about atrial fibrillation and in particular, the ABC, SEC-ABC will be, as usual, a very entertaining and interesting dialogue. And it's my pleasure now to ask Felicita to introduce our important guest. Please, Felicita.
Thank you so much, Filippo. And it is indeed. If I may ask,
sorry, we have some unmuted participants. Apologies for that.
I think they have muted. It is indeed a great pleasure to have Gregory Lip live and directly online to speak to us. I will just mention that Professor Lip is Price Evans Chair of Cardiovascular Medicine at the University of Liverpool in the UK, and also Director of the Liverpool Centre of Cardiovascular Science at University of Liverpool and at the Liverpool Heart and Chest Hospital. He is also Distinguished Professor at Aalborg University in Denmark, as well as Adjunct Professor at Yonsei University and Seoul National University in South Korea. But he also holds visiting honor or honorary professorships in other additional parts of the world, such as universities in UK, Serbia, Belgrade, China, Beijing, Nanjing, Guangzhou, Thailand, Chiang Mai, and Taiwan, Taipei. Not only, but he does practice clinical medicine for half-time, in addition to all the professorships and research, including outpatient clinics with atrial fibrillation and hypertension being his specialty services, and acute cardiology. Not only, but in 2014, Professor Lip was ranked by ExpertScape, which is an American biomedical ranking tool since 2000, as the world's leading expert in the understanding and treatment of atrial fibrillation, a position that he still holds in 2022. So, with the opportunity of having such a renowned and brilliant person, I would like to ask you, how did it all start? Was atrial fibrillation a passion since you were a child, basically? Tell us of the beginning.
Well, thank you very much, Felicita. Thank you, Filippo, for hosting me, and thank you for the very kind introduction. And you can probably see on the screen I'm blushing already with all the kind words you've been giving. Well, atrial fibrillation, and of course it is being such a common cardiac rhythm disorder, many of us, I'm pretty sure, would know someone or have family with atrial fibrillation. And my late mother had atrial fibrillation. And this was the days where I think there was a relatively lack of appreciation of managing risk factors like blood pressure, and also the importance of stroke prevention, and how things have moved on, I think, in the last decades with regard to how we approach the comprehensive management of atrial fibrillation.
Yes, it's interesting that something in your personal life often triggers a true passion. Now, you're also on writing committees. I do not know where you find the time and energy for various international guidelines, including the American College of Chest Physicians, the Antithrombotic Therapy Guidelines for Atrial Fibrillation, various guidelines and position statements from the European Society of Cardiology or the European Heart Rhythm Association. Not only, you're also senior section editor for many international textbooks and journals, including Thrombosis and Hemostasis, of which you're editor-in-chief of the clinical studies section, Europace as associate editor, and Circulation as guest editor. Now, another question, though, that I think comes to mind is the following. Within this terribly brilliant academic career, can you highlight personally one or more the most difficult moments, perhaps, of this career?
Right. Where can one start? Well, firstly, thank you for listing those things in my busy schedule, but in a sense. But I suppose to start off before I say to where it's difficult, well, all of us never stop learning, and even that's what gives me the buzz, gives me the excitement, and of course working with many colleagues, working with many fellows, and I very much always try and learn from them as much as hopefully they learn from me as well. And in terms of the difficult moments, this is where, in terms of being trying with regard to juggling all the requirements, supervision, and research, is sometimes being too much of a perfectionist. And there are a number of my colleagues who are in the audience, and they'll know that you know, if wants something to be done, it has to be done well. And in a sense, it's always asking questions, but trying to make things too difficult, in a sense that sometimes asking to be a perfectionist to make sure that we deliver the best, you know, the insight into a particular question we are asking. So hopefully that answers it. But you know, we all have our moments. But you know, what I do love about my job is you know, we never stop learning. We never stop asking questions. And with colleagues and fellows, we always learn from each other.
Yes, however, you are a tremendous combination of quality, perfectionism, and it seems to me speed and quantity. This is truly outstanding, to me at least. You have been researching a tremendous lot in stroke and bleeding risk factors and how to improve clinical risk stratification in atrial fibrillation. You contributed and actually developed CHA2DS2-VASc HAS-BLED scores for assessing stroke and bleeding risk respectively, which were first proposed and independently validated following your research and are now incorporated, as we universally globally know, into international guidelines. I noticed that you have recently published on the application of artificial intelligence in atrial fibrillation. How do you see the current avalanche of research on the use of artificial intelligence applied to 12-lead standard ECG for predicting arrhythmias such as atrial fibrillation?
Yeah, I think that's a very contemporary area of research, because that's certainly fashionable, how we try and apply machine learning, artificial intelligence to try and improve diagnosis, improve risk stratification, and in due course, management decision making. And I think this is certainly, you could say, almost the first steps, and hopefully in due course, the possibility to have real-time integrated with clinical and healthcare records and to aid and complement clinician decision-making. I very much hope that artificial intelligence doesn't replace the doctors, but hopefully are complementing some of the risk decision-making and management decision-making as well. Yes, I'm not going to claim that I'm any computer science specialist, but certainly one of the superb things about the Liverpool Centre for Cardiovascular Science, we have a very multidisciplinary group, which includes many experts in data science who have been being able to take forward the ideas, the clinical ideas proposed. And let me explain that. You've talked about stroke and bleeding risk assessment, and many of those risk scores, like CHA2DS2-VAS, or for that matter, HAS-BLED, many of them are using the more common, the more validated risk factors. And very often they are derived at a time point at baseline, and they look at an outcome 5 years later or 10 years later. So immediately you can see that that's a little bit false, in the sense that risk doesn't stay static. Risk changes over time, and in that 5 or 10 years, with aging and incident comorbidities, the risk surely must change. Now, how can we address these time-dependent changes in risk? Well, one option is employ various statistical methods, and yes, they can to a degree adjust, but you can never adjust for all the rapidly dynamic changes in risk that we see with our patients every day when we look after patients. So here comes in the application of machine learning and AI, because that can actually help with dynamic risk models. You can look at trajectories, it can look at clusters of risks, it can also, with the AI techniques, predict outcomes. It can predict what is the best management approach that should be done. And I think at the moment we are still in early days. I mean, as a proof of concept from the Huawei heart study, we were using the PPG signals from the smartware, and using that data and AI in patients with paroxysmal atrial fibrillation. Our collaborators were able to use an AI approach to predict the next episode of atrial fibrillation within the next 4 hours. So, and of course, if we can improve our prediction of things to come, it's possible to start maybe prophylaxis and to either prevent or reduce the risk associated with the episode of atrial fibrillation likely to come. So that's just a quick example, but there's many, many other aspects that we can apply AI, and particularly in relation to the dynamic nature of risks, in relation to how we can mitigate complications, and particularly with bleeding risks, and obviously with the HAS-BLED score, which deals or focuses on the modifiable bleeding risk factors for mitigation, that we can schedule the follow-ups. But of course, the big question is, how soon should we follow up? Well, maybe with AI, we can actually
It seems we're having slight technical
complications.
there we go.
We can minimize the complications.
Greg, it was frozen your image for a while, but now it's fine. Please.
Okay, sorry. I was just about to say that with AI, if you can predict bleeding, you can mitigate the potential risk, and therefore ensure that the patient doesn't get to harm.
Yes, thank you for giving us clear examples of a complex topic, the application of artificial intelligence and the importance of time and dynamics and predicting, of course, outcomes. Now let us come to the title of today's dialogue, an integrated approach to atrial fibrillation management, easy as ABC. The ABC, atrial fibrillation better care pathway, was proposed by you, and is now a core recommendation in the 2020 European AF guidelines. Additionally, it has been shown to reduce adverse outcomes in atrial fibrillation patients. Tell us more. How do you go about assessing adherence to the ABC pathway?
So thanks, Felicita. So the ABC pathway tries to bring together the various aspects of atrial fibrillation management. And of course, as a starting point, if you look to any textbook of medicine and you turn to the chapter on cardiology and atrial fibrillation specifically, what does that chapter on atrial fibrillation cover? It covers stroke prevention, it covers symptom management, rate or rhythm control, and of course, recognizing AF patients are very commonly elderly, management of the comorbidities and cardiovascular risk factors, and now increasingly attention to lifestyle type changes and the psychological morbidity associated with atrial fibrillation. And it's to distill this down that the message is the same, whether the patients managed by, and because AF is so common, they are managed by different healthcare professionals, whether the general practitioner, whether the emergency room physician, whether the cardiologist, and even within the cardiology department, managed by the arrhythmia specialists or by the PCI doctors. So we need that consistent message. And of course, finally, we have the patient and the carer. And this is basically to keep it simple, keep it practical. So A, avoid stroke, or A is anticoagulation. B is better symptom control with patient-centered and symptom-directed decisions on rate or rhythm control. And finally, the C, the cardiovascular and comorbidity optimization, including lifestyle changes, including attention to the psychological morbidity. In terms of assessing adherence, which is your specific question, well, by the book, and if we follow the guidelines, and of course, all of us say we do follow the guidelines, we should be following all of A and B and C. And the challenge is the implementation. So we have certainly looked at this in retrospective cohorts. We have looked at this in prospective cohorts, and the ABC pathway is also supported by a prospective randomized trial, and there are ongoing randomized trials for the ABC pathway compared to usual care. So from retrospective cohorts, clearly in terms of adherence, you have to pick for the A is were the patients appropriately anticoagulated. So that sounds fairly simple because guideline directed anticoagulation. So with the ESC guidelines and other guidelines globally, like the Asia Pacific Heart Rhythm Society guidelines, which also recommends the ABC pathway, the default is stroke prevention unless they're low risk. And we have to, in terms of trying to keep things simple, I don't really know how more simple can we make it. The default is stroke prevention unless you're low risk. And this is can be a message, whether it's by the GP, by the non-cardiologist, by the cardiologist, and importantly, the patient. In terms of B, patient-centered symptom-directed decisions on rate and rhythm control. Ultimately, we are trying to improve patients' quality of life and symptoms. Nonetheless, and this, in a sense, relates to the decision-making on rate control or rhythm control. And some of the historical trials on rate versus rhythm control didn't really show a marked difference in terms of the heart clinical outcomes. But that's not a one-size-fits-all type statement, because atrial fibrillation is that if you change the arrhythmia substrate early, you may well make a difference. And indeed, this has directed a lot of interest into early rhythm control for patients with new onset atrial fibrillation. And arguably, out with the context of a clinical trial where it was basically testing early rhythm control versus usual care in recently diagnosed AF, if you look in the real world practical application, which is if all of us are looking after patients, what we do find is, well, the earlier you intervene, the better in terms of the heart clinical outcomes. The younger patients, if you select, so what I mean is if you select the patients appropriately, the outcomes are also better. So it tends to be the younger patients, tends to be the patients with less structural heart disease. If you try early rhythm control in someone in end-stage heart failure, which is AF is newly diagnosed, that's probably not going to work so well. However, if you pick somebody with a reasonably normal structurally heart and recent onset AF, that's where the outcomes seem to be better, and that's what we've shown. And finally, the C, the comorbidities. The list can be very long, but if we at least even aim to target the main cardiovascular risk factors, hypertension, of course, and hypertension on a population basis is the most common reason people get incident atrial fibrillation. Optimization of management of heart failure, because now we have the different drug pillars for managing atrial fibrillation and heart failure. And I think that's the group, if we optimize the treatment and treating patients with a previous stroke or vascular disease with secondary prevention measures. But the C is not just the cardiovascular risk factors and comorbidities. Do remember things like sleep apnea. That is very frequently underdiagnosed. And in my AF clinic, we routinely, we don't screen everybody. We certainly at least ask symptomatically, because we tend to neglect asking the patients simple things like if they snore and if they are partners with them, is any apnea detected? Very simple things like this. And then you go on to further investigation. But as we've recently also published, the lifestyle factors, smoking, alcohol, physical activity, all these have implications for new onset atrial fibrillation as well as atrial fibrillation related complications. And adherence to that component, well, you can have the objective things you can adhere to, like blood pressure control, things like optimization of heart failure, management of patients associated with vascular disease, screening and detecting and treating sleep apnea. Of course, for the other lifestyle type things, it's trying to encourage the patient to cut down or stop smoking, cut back on alcohol, and increase physical activity. And those are general words of advice to our cardiovascular patients. And that also applies to atrial fibrillation. And the last aspect is, and many patients don't necessarily volunteer this, is the recognized psychological morbidity associated with atrial fibrillation. And this is particularly patients with paroxysmal atrial fibrillation, with anxiety, and also in terms of depression scores. These are things that are worth assessing the patient's level of concern or anxiety and quality of life. And in other words, you're managing the whole patient, not just a bit of the patient.
Yes, thank you for that comprehensive answer on the ABC pathway, and also for anticipating a question on the rhythm versus rate control issue, that giving us an update to the 2020 guidelines in the light of immediately following publications showing advantages of rhythm versus rate control. And also your emphasis on simple things like hypertension, sleep apnea, lifestyle, and the psychological aspects. Now, another general question. Honestly, modestly or not, what do you feel has been the most important scientific achievement as well as failure in your or the general efforts to properly manage patients with atrial fibrillation?
I suppose I've been very much interested in trying to streamline and improve the patient care pathway for atrial fibrillation patients. And what do I mean by that? Because with atrial fibrillation, this has been, it is so common, managed by various healthcare professionals. And the important thing is to try and manage atrial fibrillation comprehensively according to what guidelines tell us, and in a standardized manner. And in a sense that is evolved into what we now see in the guidelines as the ABC pathway, because and the anecdote to give you how the ABC pathway evolved, because that's, you could say, is one of the gives me a bit of a happy sense of achievement that actually is managed to be implemented. A general practitioner friend who I know socially, we met and we were just in conversation, and his question to me was, Greg, you guys in cardiology, you manage atrial fibrillation different from how we manage our patients in the general practice or primary care. And I said, no, surely not, because, that's the standard things you need to do for atrial fibrillation and manage them. And so that was that. And then you go to, and in hospital, when I'm on my rounds, meeting somebody from the from internal medicine, and I said, so in the discussion on managing the patient, this was done and that was not done. And then the comment came, well, Greg, you guys in cardiology, you manage AF very different from how we manage AF. And I said, no, that shouldn't be the case. Then we come to within the cardiology department internal meeting. So the angioplasty doctor said, well, this patient had atrial fibrillation. We haven't started any treatment because we better refer him to Greg in his AF clinic, because in the AF clinic, they manage it different from how we do. And that got me thinking. You can imagine the confusion and the concern from the patients and the relatives that they are being told different things by the GP, internal medicine, or for that matter, stroke physicians, or even non-AF cardiologists, you could say. And if they're getting conflicting information across the patient care pathway, this is where compliance with the management plan is going to be suboptimal. So it was an effort now to streamline the decision-making care pathway. And this is what we have tried and tested and trialed. This is now in the process of implementation. I mentioned before the ABC pathway has been tested in a prospective randomized trial. This was the MAFA2 trial using mHealth technology. We are running this in Europe as part of an EU funded grant called the Affirmo project. And in terms of global health, we are also establishing this as a cohorts where the ABC pathway is implemented in Brazil, Sri Lanka, and also rural China. So the fact that the message is simple enough, we can implement this throughout. You then asked where has been my most wonderful failure, and in the sense you could say it's trying to and this was a program of work, you could say a good decade or so ago, trying to see if I could improve stroke risk stratification or risk stratification by novel and more novel and even more novel biomarkers. And what do I refer to by biomarkers? Biomarkers can be either urine biomarkers, blood biomarkers, and of course imaging biomarkers. They are after all biological markers. And of course, the quest for finding new biomarkers is never ending. So you find one new biomarker, the next one comes along, and you have to test the next biomarker, and then the next biomarker, and then to the stage when when we try and publish the paper, the reviewer and the editor comes back and saying, yes, you have this new biomarker, but have you compared it to the old biomarker? So the cycle starts again in a big circle. So it's this continued quest to find higher risk patients with more and more biomarkers. So rather than starting, and I suppose the counter arguments are, firstly, many of the biomarkers are non-specific and they reflect a sick patient, or you could say a sick heart. Secondly, many of the biomarkers, even though some are proposed as specific for bleeding or specific for stroke, well, if you look at the literature properly, they don't just predict stroke or bleeding, they predict heart failure, they predict acute coronary syndrome, they predict vascular disease. So many are non-specific. And on the practical point of view, and if many on this call are actively looking after patients, well, would you see a patient with atrial fibrillation, check one biomarker? Well, in fact, why do you want to stop at one biomarker? Why don't you add 2 or 4, 3 or 5 or 10 biomarkers sequentially and see whether that's going to improve the risk stratification? Then come back in 2 weeks when we have all the results and we'll tell you if you're high risk. So practically, there's that aspect. So I must say, I've spent many of my hours trying to chase biomarkers. The first paper to add a biomarker on top of clinical risk stratification is something we published in Stroke in 2006, where we added in one Willebrand factor on top of the CHAD score, on top of the Birmingham score, which today we know as the CHADS-VASc score. And of course, no big surprise, this blood biomarker refined clinical risk stratification. And that's a general statement. Every biomarker type study shows that biomarkers will refine and improve on clinical risk stratification. But the challenge is the variability, the costs, also the non-specificity, as well as the percent some biomarkers, a diurnal variation as well. So these, I think, are challenges. And so I suppose you could say I did try and start that line of research. I did answer some questions, but in terms of a spectacular failure, I don't think I really answered the question fully.
Nonetheless, it sounded like an honest response, and thank you for highlighting the confusions that patients may perceive when medical pathways diverge from one healthcare provider to another, and also for your assessment of the challenges posed by biomarkers. We have a question from someone I see in the audience, Fabian Barbieri. If you unmute yourself and pose your question directly to Professor Lip.
Thank you very much. I hope everybody can hear me. So my name is Fabian Barbieri from Berlin. And I wanted to know from you if you could please elaborate about the different phenotypes and genotypes of atrial fibrillation you personally distinguish and what mechanisms stand behind. This is especially of importance since the new AFNET statement was made about the NOAA trial, and the NOAA trial was stopped due to failed efficacy of the NOACs in patients with a CHADS-VASc of more than 2 and are on the devices.
Okay, thanks. I think that's a great question. And like with many things in cardiology, atrial fibrillation is not a single entity, it's not a yes-no condition. And in terms of phenotypes, you can look at this in different ways. There's the sort of phenotypic characterization with regard to the different aspects of the arrhythmia. And you mentioned a NOAA trial, and that was, of course, the atrial high rate episodes detected by devices. And of course, now that we are in the era where we have improved ways of detecting atrial fibrillation, smart watches, smartware, more sophisticated devices that can pick up many episodes of atrial fibrillation, which are without symptoms, sometimes even called subclinical atrial fibrillation, and even to the patients with established atrial fibrillation, there's obviously the old categorization of paroxysmal and persistent, and for a point, long-standing persistent and permanent, and those are the kind of clinical characteristics. There's also the underlying, in terms of phenotypic characterization, there's also the underlying phenotypic clustering of the associated risk factors, because very often atrial fibrillation does coexist with comorbidities. And that's a line of research that I think is really important, because we've tended as a specialty to regard risk factors in isolation. Oh, he's a patient with AF and heart failure. Well, the patient with AF and heart failure very likely will have hypertension, or for that matter, diabetes, or for that matter, vascular disease, or very often all of the above. So you get these clusterings of risk factors, and this is as I mentioned, some of our fellows, and some of whom are very nicely in the audience, are also been investigating this, because the outcomes are clearly different. And if you of course, one of the phenotypic sort of categories that has been described, the so-called lone atrial fibrillation. Now, I would counter that by saying, how lone is lone? Have you looked hard enough for the associated risk factors for atrial fibrillation? And the ERA consensus document does try to make that point, actually. If you lone AF really should be a diagnosis of exclusion, and to be honest, there's going to be really few of those. And back to my point I mentioned before, in terms of phenotypes, the risk doesn't stay static. So what you perceive as so-called lone AF today is definitely not going to be lone AF tomorrow. And we showed this in the Taiwan registries, and also in Denmark as well as in Korea, how a patient initially with a CHA2DS2-VASc score of 0 in males or 1 in females, so conventionally low risk, in the next 4 to 6 months, they would develop 1 or more new onset comorbidities, which are detected. So risk isn't static, risk is dynamic. So that's the phenotypic. When you come to the genomic, it all gets more interesting as well. But of course, we are talking about a global cardiac arrhythmia. It's not something confined to us in Europe, nor is it confined to certain parts of the world. And indeed, there has been that interest, previous interests in fact, there still is, it's not previous, it's still interest into so-called familiar AF, where it seems to appear in clusters amongst family group members. And there was some wild excitement, I must say, that they found a gene for AF. And of course, a separate group in US and a separate group in Asia start saying, oh, well, but we've also found a gene for AF, and they're not the same. So I think the challenge with a condition like atrial fibrillation, you're open to a lot of heterogeneity in terms of the underlying genetic mechanisms, the underlying phenotypic presentations. And the phenotypic presentations can be related to the phenotypic heterogeneity in the comorbidities or multimorbidity, and as well as the phenotypic differences in terms of the rhythm. So, because this is all multiple levels, you can not unreasonably conclude atrial fibrillation as a multifactorial condition.
Thank you very much.
Yes, thank you for asking this question. There are a couple of other questions, but I want to hand over really to the editor-in-chief of the European Heart Journal, who actually is the founder of these dialogues, to have him pose questions to our distinguished guest and handle questions from the audience.
Thank
so,
you,
Filippo.
Thank you, Felicita. Thank you, Greg, for this wonderful conversation. Yes, I encourage the audience to ask questions via chat, or they can raise their hand and we can unmute you and you can ask your question personally. Now, let me continue with our audience. First, let me thank Ruth Amstein from Zurich for her kind words. She writes, great platform and interesting discussion. Thank you, Ruth, for your kind words. And then we have an interesting question, very practical question from Annabelle Folkman. The question is, what about pill in the pocket for paroxysmal atrial fibrillation? What is the role?
I think it does have a role, because it certainly is, and we still use it, and it is certainly suitable for some patients where they have at least a documented responsiveness to the particular antiarrhythmic drug. This has been tested, for example, with flecainide, propafenone, for example, where there's a good response within a decent time period. Now, there are, in terms of application, I think firstly we need that the patient does understand how to use it sensibly. Secondly, because this would be also for the patients with, you could say, arguably few symptomatic or episodes of atrial fibrillation where the pill-in-the-pocket antiarrhythmic drug may be helpful to terminate a symptomatic episode. That's with the caveat that only 1 in 12 episodes of paroxysmal AF are actually symptomatic, because a lot of AF occurs asymptomatically. The principles of ABC pathways still apply, because if the patients have risk factors, it's not a matter of whether they get AF or not, it's their comorbidities. So the A still, in terms of stroke prevention, avoiding a stroke still applies. Better symptom management applies, because after all, that's what the pill in the pocket tries to terminate, a symptomatic paroxysm. And the C, of course, if they have their comorbidities, that needs to be addressed as well.
Thank you, Greg. I see Annabelle Bolgman raising her hand.
Thank you, Dr. Lip. I'm a huge fan and have read many of your papers. I learned so much from you, so thank you for doing this. But my question was actually pill in the pocket anticoagulation, not antiarrhythmic drug, because as you may know, Rod Passman just got NIH funding to study a pill in the pocket approach for anticoagulation for patients who we normally would be giving ongoing anticoagulation. And I'm a little, worried about, a lot of my patients are asking me, I haven't had AFib in 5 years. Why do I still need to take anticoagulation? And I'm reluctant to stop it because of the fear of stroke, of course. And the patients don't want to have strokes. And I don't want to give them a higher risk of bleeding. But I think there are definitely, just like the genotypic phenotypes and phenotypic genotypes, I think there are phenotypes. I think there are certain patients who don't really need long-term anticoagulation, but we still don't know who those are. Do you agree?
Yes, indeed. I was initially going to cover the antiarrhythmics, and I was then going to come to the pill-in-pocket anticoagulants. And you're right, I'm aware of Dr. Passman's trial. And yes, there are many patients who have had a remote known episode of AF many years ago, and now they haven't anything documented. And I suppose the thing about management today and why that trial I think would be really interesting is the fact that we're now in the era of wearables and smartware. So like the Apple Watch, and of course we in ran the Huawei base MAFA trial in China, where again you could pick up episodes of AF early. So in the patients who've had few and far between episodes of atrial fibrillation, that's really a possible it's a possible strategy that if they've documented short episodes of atrial fibrillation, particularly if they have a way of detecting it with smartware or smart technologies, and they get few and far between episodes, then they get at the moment, I understand the protocol is after the episode, they have to take anticoagulants for 4 weeks afterwards. Then, if they've got no further episodes, it potentially could be discontinued, which is what is being tested in the trial. I'm not preempting any results, but before the era of smartware to be better at picking up atrial fibrillation, we've generally stated that, well, because many episodes of AF do occur, we don't know they get occurring because only 1 in 12 are symptomatic, so symptoms are not a good guide. So the decision was based on risk factors. But now the fact that we can pick up the atrial fibrillation, I think this is a really interesting trial. And, potentially we'll look forward to see what the results show. As long, that is with the proviso, the patient does actually get, make sure that the smartware does pick up the atrial fibrillation.
Well, this is becoming an interesting session, like those we have the best Congress in the world. But really, I'm enjoying the fact that it's so interactive. And now we have a question from Martino Pengo. Amelia, can you unmute Dr. Pengo? Can you introduce yourself and ask the question?
Hello, everybody. Thank you, Professor Lip, for your availability, and thank you to the European Heart Journal for this great initiative. So I work in cardiology and in the field of sleep disorder breathing. So you briefly mentioned previously the importance of asking questions like snoring in patients with AF to possibly help with the diagnosis of sleep disorder breathing. Now, my question regards the role of treatment of sleep apnea in patients with AF. Some of the recent trials were somewhat disappointing or at least conflicting in terms of results. And I wanted to hear your eminent position on this. So which is the role of sleep apnea treatment at this present stage in patients with AF at each stage of their disease, so pre-ablation, post-ablation. So how important do you think it is treating sleep apnea to reduce the recurrence of AF? Thank you.
Yeah, thanks for the great question. And I think you're referring to a recent trials, particularly related to the recurrence of AF post-catheter ablation, which have not been perhaps as stunning as one anticipated. But however, do bear in mind the sleep, of course, this is your specialty. Sleep apnea patients very often have the concomitant hypertension, the concomitant obesity, some of them may also be smoking and the other comorbidities. So in a sense, I think sleep apnea diagnosis and management is one component of the C of the ABC, because very likely just attention just to a single component is not going to be necessarily showing the big benefit, particularly on hard clinical outcomes. So what do I do if I've got the patient diagnosed in my AF clinic with sleep apnea? They would very often come, because the sleep center is a separate hospital, they will come back to the next follow-up very often, telling me quite happily they're on CPAP and in fact feeling so great. They got more energy, they can breathe better, they're not snoring so much and not so sleepy in the daytime. And then I said, that's great. Why have let's just work on your blood pressure, weight reduction and, all that other aspects as well. And I think if we want the hard clinical outcomes, we have to go back to this holistic or integrated care management.
Thank you, Greg. David Jenkins, before I'm muting you, David, just have one burning question for Greg Lip. Then I will ask you to ask your question. Greg, a burning question. What about wine and atrial fibrillation? We know that moderate consumption of wine is associated to lower risk of myocardial infarction. But when we come to AF, apparently, one glass of wine per day increases the risk. Do you drink wine? This is my question.
Occasionally, because that it's to help the psychological morbidity, because it does in a bit of a social circumstance. It's not a bad thing to do, but in occasional and certainly in moderation, yes.
But what about the risk of AF with really a very small amount of wine? Is the risk there? Do you think patients will show?
At least if you go by the epidemiology, there is you could almost say there's a dose response relationship to a degree of incident AF as well as AF related complications. So one of our recent studies from Korea was that after the diagnosis of new onset atrial fibrillation, the alcohol abstainers, in fact, this translated actually, the alcohol abstainers after new onset AF diagnosis were associated with less clinical adverse outcomes, whereas those who continued or increased their alcohol intake after atrial fibrillation diagnosis did worse. So I think, as with many of these things in life, it's be sensible and in moderation and nothing excessive.
Yes, for sure. Thank you. Does this apply to Italian wines as well?
We, I'm afraid, never had that access to the data set to
Perhaps
compare the countries.
A special study on that. David, thank you for asking your question.
Thank you very much, and thank you for this tremendous symposium. I'm just wondering, do you see any advantages apart from symptomatic for early catheter ablation?
answer is yes, in the sense that I made the comment before on a little bit of that discussion on early rhythm control, because a lot of interest has been directed again to the possibility of early rhythm control, and this was because from the older historical trials of rate control versus rhythm control for all comers, it didn't really make any appreciable benefit on mortality or heart failure or stroke. But the more recent a more recent trial focused on early rhythm control suggested a benefit in the 21% benefit reduction in the composite clinical outcome, and that therefore raises the possibility, if we intervene early and change the substrate related to atrial fibrillation with early rhythm control, including catheter ablation, you improve outcomes. And the answer is yes, because we certainly out with the trial setting, and if we do this in real world clinical practice, what we've shown is that, in fact, the earlier the better. So the most benefit is in the first 3 months or so. And then the best benefit is if you intervene in the younger patients with less structural heart disease. One of the interesting observations from the ESC EORP registry is that the patients with AF onset within 1 year, if they had rhythm control, their outcomes were not significantly different to if AF patients had no rhythm control but were fully compliant with the ABC pathway. So it raises the question whether, at least in a trial setting, patients had a better package of care with regard to managing their anticoagulation, their comorbidities, etc. More physician contact and optimization of their overall care pathway.
Thank you. So better care, actually, is probably better.
Like the atrial fibrillation, better care pathway.
Thank you.
Thank you, both of you. Felicita, I'm sure you have additional questions, please.
Thank you, Filippo. Well, there's an interesting question that was received by email. It actually asks, Greg, how much do we know about right atrium taking part in atrial fibrillation?
That's a good question, and I'm afraid I think the right atrium is a little bit of the twilight zone or the silent zone when it comes to, and I'm very often asked, what about thrombus in the right atrium, and why is it not manifest in the AF patients? I think the right atrium is a little bit neglected in general cardiology compared to the left atrium, especially for atrial fibrillation. I'm pretty sure clots may well occur, even though the right atrial appendage has a bigger inlet size compared to the left atrial appendage. But if any, but in terms of the arrhythmia focus, well, it's I think the general thought or the general understanding now is the pulmonary veins are the main source of pulmonary vein foci precipitating atrial fibrillation. But I suspect on the right side, you may not necessarily have that kind of arrhythmogenic activity, but maybe it's not impossible if you've got some rogue atrial myocardium in some of those vessels.
Yes, thank you. Now, I can't avoid asking you about patients with atrial fibrillation undergoing PCI and your views on triple versus double antithrombotic therapy. Do you believe there is a sweet spot in terms of duration and perhaps composition of treatment?
Again, I think this is a group of patients where we will need to look at the associated clinical scenario. And what do I mean by that? There are certainly some patients who are at high thrombotic risk and may well require that initial period of triple therapy. And this is an anticoagulant, aspirin, and a P2Y12 inhibitor, usually clopidogrel, following which you can drop the aspirin and continue with dual therapy with an anticoagulant and a P2Y12 inhibitor up to 12 months, and then an anticoagulant alone. Now, some of these patients, particularly at high thrombotic risk, recent acute coronary syndrome, for example, lots of metal in the arteries, maybe a left main stent, and then, but on the other hand, that has to be balanced against the potential for bleeding risk. So if you've got a very elderly patient, very high Hasbled score, multiple hospital admissions with particularly GI bleeds, well, you may, and there's an acceptable thrombotic risk, you may well drop the aspirin right from the start. In other words, an anticoagulant with a P2Y12 inhibitor. So we need some degree of individualization for the particular patient. We are also in the situation where the technology is getting better. We are having stents that are lower struts, smaller strut sizes, and of course better imaging, because one of the main concerns or main arguments in the past for having more prolonged triple therapy was the risk of stent thrombosis. Well, we're getting better at trying to deploy these stents. There's now OCT to be able to ensure good apposition and stent deployment. So as the technology is getting better as well, you can see why recent guidelines, they're shortening more the period of required triple therapy, if at all, that we need to continue on that. And afterwards, the main duration of treatment is with an anticoagulant and a P2Y12 inhibitor. And that seems to be borne out by some of the trials, particularly nowadays with the NOACs in that clinical setting.
Yes, thank you. Another question I can't avoid asking you, and I've actually asked you before today. The CHA2DS2-VASc, as you pointed out many times, is helpful to sort of decide where anticoagulation is in a truly low-risk patient may not be necessary. The female sex item increases thrombotic risk, but at higher CHA2DS2-VASc scores, you have taught me. So is it really a practical necessity to have that sex item in the CHA2DS2-VASc? Should it become CHA2DS2-VASc just to make things simpler in the future?
Well, I suppose there's a question of how the risk score was defined and validated. And in a sense, you could, if the default is stroke prevention unless low risk, then the initial step, you're looking basically at patients with CHA2DS2-VASc score 1 in males. So a CHA2DS2-VASc score 0 in males or 1 in females, or a CHA2DS2-VASc score, as you call it, of 0 totally. But what we have in published literature is certainly within the first 4 months or so, they would acquire 1 or more new comorbidities. And once they have 1 or more new comorbidities, having female sex, which is a risk modifier rather than a risk factor, increases the stroke risk. And the stroke risk starts to get more and more, as you accumulate more non-sex stroke risk factors. That's quite important in terms of counseling patients and general practitioners on the importance why these patients should maintain their anticoagulant, because perhaps more challenging rather than the view of whether we go with CHA2DS2-VASc or CHA2DS2-VASc, more important is the fact that female patients with atrial fibrillation tend to be underdiagnosed. They tend to be under, in terms of anticoagulant prophylaxis, they tend to be suboptimal compared to many male patients. And I think that's an injustice. If anything, I would, the fact that if we keep CHA2DS as it is now, it highlights the fact that females are important. We always knew females are important, so this is a good way to ensure that we don't forget the stroke prevention aspects here. We avoid the undertreatment, we avoid the underdiagnosis, and having female sex as a risk modifier and showing clearly from well-validated studies that it adds to risk, stroke risk, or it modifies the stroke risk. And guidelines have to follow evidence. Not so, the guidelines are meant to be evidence-based, not eminence-based, not VIP-based. It's not in a sense that if we have the evidence from well-validated studies consistently that female patients should get the appropriately anticoagulated, and the fact that being female adds or increases the ischemic stroke risk, then that's what should be encouraged.
Well, thank you, Greg. It is already 1 hour. We are chatting. It's been really fascinating. Looks like 10 minutes rather than 1 hour, because the conversation has been really interesting. I have one last question for you. Well, let's come back to your prodigious scientific production. 3,000 papers, including 700 reviews and 70 guidelines and position papers. Really remarkable. But as editor-in-chief of the European Heart Journal, I'm even more impressed about your activity as a reviewer. And indeed, in 2021, you've been awarded as the elite reviewer of the European Heart Journal. Although was not in places 2 years ago, Greg, but I mean, was anyway a very well-deserved and intense award. So you're in the best position to tell our young reviewers, what are your suggestions to write an excellent review, and how can you find the time?
Right. So how to do a good review for a journal, I presume is your question, Filippo, yeah? So,
Please, yes.
Well, I enjoy doing these reviews because, as I mentioned before, we never stop learning. And this is a good way to learn about a topic and also to keep abreast of the literature. Reviews for top journals and like European Heart Journal, I think it's a matter of trying to distill the particular manuscript you're reviewing to highlight the strengths, highlight the deficiencies, and very often in terms of reviewing a manuscript, it's important to put the new work in the context of prior work, and I think this is that does depend on a little bit of homework on your part as a reviewer, because this morning I was doing my quarter reviews this morning, and for example, one of the manuscripts was saying this is the first ever study that has done this or done that. Well, this was an atrial fibrillation related topic, and just reading that I said, well, no, that's not true, because then quickly on PubMed you can find out the half a dozen other studies that have actually addressed the same question. So you have to be able to have some insight into the literature and whether or not some of the claims or the over-enthusiastic claims by authors are appropriate, and flag this up to the in your comments, because when it gets to the editor needs to make a judgment, of course, whether the novelty, whether this is an extra value or contributing to the literature. And of course, is the science robust? Because it's no point trying to do, for example, a score validation study with 50 patients, maybe 50,000 patients, that might be a different discussion. But to do a score validation of 50 patients, And if the C index, for example, is 0.51, that's slightly better than tossing a coin. That's not going to be very helpful either. Certainly wouldn't make it to European Heart Journal, that's for sure.
Well, thank you, Greg, for these suggestions to our younger reviewers. And I take this opportunity also to thank our reviewers. They make an excellent job, and this is vital for the journal. And again, I can anticipate that in the next few weeks, we will have one issue where CardioPulse will be entirely dedicated to our reviewers. Well, this brings our discussion to the end. Greg, thank you again for the time dedicated to the European Heart Journal. Felicita, thank you. Felicita, thank you for entertaining with us this very interesting conversation. And I'm happy to tell you we will have, as usual, a new dialogue in October, precisely on October 27th, as usual, at 17 Central European Time. Greg and Felicita, thank you again for this wonderful hour we spent together, and thank you to the wide audience in several continents joining us for this pleasant hour. Bye-bye.
Thank you. Pleasure.
Bye-bye. Thank you.
Thank you, Greg, and thank you, Filippo.
Thank you very
the
much.
audience.
Thank you, everyone, for joining, and we'll just wait for everyone to sign off. Many thanks, Professor Lip.
No, delighted. That was great fun. Thank you.